All right, guys, I think we're going to go ahead and get started. It is my distinct pleasure to welcome Dr. George Sakoulas. Is our ID Grand Round speaker today and also our keynote speaker at the Sudani Symposium tonight. I've known George for a long time. I knew him when he was a resident, and then he was a fellow who was 2 years behind me. George is now a active clinician in the Sharp healthcare system in San Diego. He's chief of ID at the Sharp Rees Steely Medical Group. He's also an adjunct professor in the Division of Host Microbe Systems and Therapeutics, Center for Immunity, Infection, and Inflammation at UCSD. He's been practicing clinical ID for 22 years. He went undergrad at Columbia. He went to Harvard Medical School, which I'm not going to hold against him, but he turned out fine. That's all that matters. He completed his clinical training in internal medicine and ID at Beth Israel Deaconess Medical Center in Boston. George has done really incredible work. And when I think of translational research, I think of George. He is a clinician first, but he's also a researcher first, and he marries the two. He's always thinking outside the box and trying to push science forward. He has particular interest in relationships with antimicrobial resistance and bacterial virulence and interactions between innate defense and administered antibiotics. He is trying to work towards developing more effective contemporary therapies for common severe infections by utilizing available drugs. I think Enterococcus and Staph aureus come to mind in those categories with some of George's leading work. I could go on for a long time, but I want to hear from George. So with that, I'm going to turn this over to Dr. Sakoulas. George?
Thanks, Keith. Thanks for the privilege to talk to your group today. I don't really, find myself anybody that, people want to hear from too much, but I really appreciate the honor and the privilege to be able to speak to you and share some of my thoughts, and hopefully provide you a little insight on how I kind of view our field of infectious diseases, and particularly as it relates to Staph aureus endocarditis. So Staph aureus is, as many of you probably know, is the most common cause of endocarditis in developed countries. In less developed countries, viridans still predominate as common pathogens. But if you think about it, right, I mean, in developed societies where dental hygiene and is, better access to, and we put in a lot of skin devices, whether it be procedures or catheters, we're getting free access of our virulent skin pathogen, access to the bloodstream. It makes sense that the skin pathogen is going to supersede an oral pathogen as the most common cause of endocarditis. There's a huge unmet need, I think, in terms of how thought leaders view this disease. I was talking about over lunch, kind of joking about it, how sometimes I'll see a board review question and, vegetation 0.5 centimeter in a, IVD substance abuser, and the treatment is vancomycin. And it's like, my answer out of my mouth is, are you kidding me? Even though that's the answer that the boards want you to ask. So I think there's a big gap between what we know biologically, what we know from some of the lower quality data, but what, sort of the leading authorities tell us the answers are. So these are my disclosures. So I want to sort of pose this analogy to you of how we study antibiotics in the context of a different physiological residue. So many of you probably know VO2 max, right? That's your maximum oxygen consumption. It's a marker of physical fitness. And if you look at this, the American Heart Association determines this as the overall strongest predictor of health. In other words, what your VO2 max is, how much oxygen your tissues can consume, is pretty much the best metric of your status as a physiologic organism. So what do I take this up? Because what heterogeneous valuable, it changes with age, it changes with sex. It's better when you're physiologically taking care of yourself. It's brought down by comorbidity. So it's sort of a surrogate of immunity, right? So there's a parallel between what happens to the innate immune system and VO2 max. Now, the innate immune system is relevant when it comes to fighting infection, because that is what our antibiotic therapy that we are treating patients with is cooperating with in order to take care of an infection. So Let's say I'm a drug company, and not developing an antibiotic, but I'm developing a drug that after 3 days, let's say you take it for 3 days, and it's going to increase your VO2 max by 30%. So it's going to result in you running a race faster. So how do you test drug X, right? So actually we do it in the audience. Give drug X to a group of healthy volunteers and measure their VO2 max before and after. B, give drug X to healthy volunteers and measure their 5K race times. Or C, find a 5K race, get 100 runners and randomize them. 50 to get you get drug X, 100 to get drug X, and 100 to get placebo, and then you see what their race times are. So, a show of hands, how many of you would use A as a surrogate to say, okay, I'm going to use this drug as a athletic performance drug? What about B? What about C? Right, C, exactly. Right. So that's the metric that we use when we are assessing antibiotics, and that's the answer I would have expected you to give. But what happens in the real world, right? The VO2 max depends on many factors, right? Now you have to start finding, if you get a race, right, you're going to get 20, 30, 40, 50, 60-year-olds. You're going to get couch potatoes. You're going to get, people that run all the time, people who would never run a race in their life. You're going to run different sexes. You're males and females. You're going to measure how, you're not going to, there's measures of how hilly a course is and what elevation is being run. Is it 7,000 feet, 9,000 feet, sea level? What time does a race start? Is it midnight, or is it one of these midnight runs you do around New Year's, or is it going to be one of those that you do, at 8 in the morning? What if you start comparing drug X versus drug Y in this complex equation? Most important question: what is your basic level of fitness entering this race? Right? Where is the starting line? You might say to yourself, "Well, why am I asking that?" Patients come to us with acute infections at various courses of their illness, right? So you don't even know where the starting line is. You're going to measure times where you don't even know where the actual patient, there's variability in all these other things on top of where the starting line of the race is. So look at baseline VO2 maxes, right? You have patients who are, 20 to 24, top physical condition, 62, right, liters per minute, versus, someone who's 50 to 55, you're going to go down to 22, 26, 21, 24. 30% changed by a drug is going to be nothing. It's going to be a drop in the ocean on top of this baseline variability that you've already got built into this physiologic variable. So again, most of you picked C because this is the level 1A evidence that everybody strives for. But I think if you really think about what you're trying to do, you really can't measure drug X in a race. You actually the only way you can really do it is if you give it to folks and measure their race times, individual patients, measure their times before and after and see how they do. So this is considered anecdotal, low quality case reports, but you see the value of measuring, an agent such as this. So I throw this out to you because we automatically strive for C. Everybody just knee-jerk, and unless it's C, we don't even want to look at it. But think about hopefully that scenario and that metaphor threw out to you how we're really missing a big component of granularity in assessing the effects of our antibiotics on the measurement of infection when we're talking about acute infections. When we're talking about a more stagnant or stationary condition, like when we're talking about hypertension, cholesterol medication, even HIV. If you enroll a patient with an HIV for the HIV with for antiretroviral therapy today versus next week versus next month, it's the same patient. It's a steady state. A patient who gets enrolled in an acute infection, whether they come in early or late, they get enrolled day 1, day 2, day 3. COVID taught us this, right? With COVID, we learned that a patient at day 3, 4 is in the viral stage, right? They get better and they get super sick. They're more in the inflammatory stage. And it is no surprise that our COVID therapy, our biggest success with COVID was really in the vaccination world. I mean, if you look at therapeutics, you could throw a couple thousand patients together, give a p-value less than 0.05, and you say tocilizumab reduces your mortality from, let's say, 22 to 20, from 27 to 22%. How comfortable is your patient going to feel when you say, "Oh yeah, sir, I'm going to give you this med, your mortality is going to go from 24 to 21%." Okay, well, good. P-value less than 0.05 because they got an N of 4,000 patients. But how significant is that in the real world? And so I post this out there because I think it's leaving our drug, our therapeutic recipes and therapeutic strategies behind, looking for this class C evidence that really either doesn't exist or is going to be impossible to get. And even when we get it, what are we actually measuring? Um, so when we're treating infections, I want, I guess one of the things I want to kind of get people to think about is it's carrying, getting rid of an inoculum, like carrying, it's like covering a distance. And how far you travel is, well, how far your trip takes is a function of how far you have to go and how fast you're going. In ID, we have this mentality, this preset mindset of we're going to treat this for 6 weeks, osteo 8 weeks, endocarditis 6 weeks. Like the bacteria have a lease and they're going to pick up and leave when their 6 weeks is over. I mean, they may, some people might be done at 4 weeks, some people might be done at 8 weeks. So I think there's a lot of variables we need to sort of consider in patients when we make decisions about what drug and for how long. What's their immune status? Just like with the VO2 max, what's their fitness level? How much distance do you have to cover? What's your inoculum? The activities of the agents you are using. Maybe if you're not covering as big a distance, i.e. you have a lower inoculum, you could afford to use a slower moving agent, i.e. a less active agent. When you have a lot of ground to cover, a big inoculum, maybe you need to use different therapeutic approach that covers more ground more quickly, i.e. a more spectrucidal drug. And, the cytostatic, I don't want to get into that discussion because that's a whole other can of worms that we really have no way of measuring the way we measure MIC. So, this is, the analogy of, you have an infection, antimicrobial therapy working together with host immunity. As the host immunity gear gets smaller, you're going to have to push a lot harder on this side of the pedal along these loops. So with MRSA endovascular infections, I tell folks, be prepared for salvage. When Vanco is plan A, you're definitely going to need a plan B in a lot of cases. If you truly have an endocarditis or an endovascular infection, as you know, plan B, when you have to go to plan B, patients usually have longer length stays, more complications. Things tend to go wrong when you have to go to plan B. And that happens in oncology as well. We all know that once our patients go on second, third, fourth line therapies, chances are they're not going to win that battle. So it's always good to get it right with plan A. So I want to start off with this line of reasoning that we came around back in 2009. This is about a year after I moved to California, where I got called by a colleague at New York Medical College, where I just left the year before. And he had a patient with a MRSA bacteremia for 21 days. I tried back in those days. He had vancomycin, pushed for TROS 15 to 20. Then he went to Dapto 6 mg per kg. Then he went up on the Dapto to 8 with Gent. Then he, he called me, 21 days into it, and then he's like, "What? I don't know what to do at this point. Should I give linezolid? Should I add linezolid?" So I read this paper, showing the synergy between daptomycin and nafcillin, and I said, "Why don't you use Dapto high dose 10 and add nafcillin?" And he thought I was crazy because the bug was already a MRSA with an MIC of tenafcillin of 128. It was already a Visa with an MIC of Vanco of 4 and a Dapto non-susceptible with an MIC of 2. So I said, "Well, what beggars can't be choosers. You've got 3 weeks of bacteremia with no source control options. What do you have to lose?" So anyway, he took a leap of faith. It's always nice to be on the other end of that equation, right? Because you're 3,000 miles away. You have no responsibility in that. So, but he took the leap of faith, and actually he called me up very ecstatic a few days later. Said, "George, ever since I made that change, the bacteremia cleared. And these are 2 antibiotics that the microbiology told you are, resistant, right? Non-susceptible, which means don't use." And just as a little aside, I look at MICs the way we measure them today as analogous to measuring someone's blood sugar by tasting their urine. I kid you not. It's it's so cursory and rudimentary that it gives you a ballpark, right? Urine's kind of really sweet versus not so sweet. High sugar, low glucose. That's basically what we're doing. I kid you not. If you actually see what we can actually do in measuring susceptibility testing and physiologic media, and I can get into that if you want in the post-meeting discussion. So we did some studies showing that there's a synergy with dapto and nafcillin, and you can actually enhance that binding of daptomycin to the membrane. And we think this is happening because the nafcillin, even though it's not killing the organism, it's underlinking the cell walls are opening up, and so there's access to the daptomycin through the cell wall that's under cross-linked to the membrane below and is able to work well. Well, that whole finding was nice, but it also opened up this whole avenue of understanding because we knew that daptomycin, when bound to calcium, is a de facto antimicrobial peptide that kills bacteria in an analogous way that many antimicrobial peptides that our immune system makes. So catheliocinin is one of them. L37 is the human form, cramp is the mouse form. And these antimicrobial peptides are ubiquitous in nature. They're found on the surface of amphibians. They're on the surface of, actually, many of you may not know this, but if you take an egg from a chicken, if you never wash the egg, you can keep it at room temperature, right? Because there's antimicrobial properties on the surface of the egg. Once you wash the egg, which what a lot of commercial eggs do because the chickens are sitting there and just pooping and laying their egg in the same place. You got to wash them, then you've got to refrigerate them because all the antimicrobial properties on the surface of the egg gets washed away, and you have to refrigerate the egg. But if you don't do that, the antimicrobial properties on the surface actually allow it to survive or not get contaminated at room temperature. So there's many of these. Catheliocinin is one. Human neutrophil peptide 1 is made by neutrophils. PMP is made by platelets, and this is actually a very important one when it comes to endocarditis, beta defensins. And it turns out that bacteria can become relatively resistant to these peptides because these are cationic, right? So if you increase cationic charges on the surface of your cell, you can actually develop this more relative repulsion. So if these are more, if there are mutations in various genes, NPRF or DLT, that increase the positive charge on the surface of the bacteria, there's going to be relative resistance to these antimicrobial peptides. So it turns out that, well, if nafcillin enhances daptomycin's activity, it should be able to enhance the activity of other antimicrobial peptides. And sure enough, if you take, these are actually the strains from the patient. 592 is the original strain from day 1. 712 is a strain that came out of the patient at 21 days, the last day of bacteremia. If you grow up the organism in nafcillin at well below MIC, and then wash it off and then expose it to killing assays by the antimicrobial peptide, you see that the nafcillin exposed organism gets killed dramatically more. And it happens in a dose responsive fashion. If you have no nafcillin, as you go, even at concentrations as high as 1.5 micrograms per ml, this is almost 100th of the MIC, you're starting to see an effect on antimicrobial peptide killing on this particular strain. Other beta-lactams do it as well: ampicillin, piperacillin, cefazolin, ceftriaxone, nafcillin. Other MRSA agents do not have this property. Linezolid, daptomycin, vancomycin. If you grow the bacteria up at sub-MIC concentrations, you're not enhancing this killing. And we try this against various other strains, including the Versa strains from Michigan, Versa strain from Pennsylvania, the Visa strains from actually here in New Jersey. Actually, the strain came 5836. And you can see in all cases, there's an increased killing, or i.e. reduced survival, when the bacteria were treated in the presence of nafcillin. And this also translates in whole blood killing, neutrophil killing. I won't go because into time, but there's you enhance overall general immune killing of the organism, including with antimicrobial peptides by exposure to nafcillin. So we're learning that beta-lactams, many of us in ID, really reach for beta-lactams in the most severe patients with endocarditis, severe infections in the ICU. We're not resorting to quinolones or tetracyclines or non-beta-lactam drugs. We really rest our efforts on treating patients who are super sick with beta-lactams, and we're learning now that that S for susceptibility means more when it comes from a beta-lactam than it does for other drugs. For example, and this is, you could look at the reference here and look at this article, but the point is there's all sorts of virulence reduction. There's cross-linking of the cell wall is reduced. There's actually IL-1 release that's enhanced, and I'll talk a little bit about later. Look at these virulence factors on Staph aureus. So this is actually for the strains that I just talked about. If you grow it up in nafcillin 5 micrograms per ml and look at the protein amounts of various virulence factors on the surface, clumping factor, fibronectin binding protein, and protein A, they're reduced multiple folds. I look at this slide and I think to myself, there are companies out there that are developing monoclonal antibodies that are neutralizing these virulence factors. And I'm saying to myself, nafcillin just makes them all go away. Why am I going to use an antibiotic that's going to cost, thousands of dollars when I've got an antibiotic that's going to make them all fall off the surface and create these dramatic responses? So I think if we really took a look at our antibiotics and put them under a microscope, in what they're actually doing, we might be able to get more mileage out of them and not have to resort these very expensive and elaborate schemes that sometimes we go after because they sound cooler, right? It's a lot cooler to say, oh, I gave a patient a clumping factor, a monoclonal antibody, than I say I gave him nafcillin, right? So it's but and somebody's going to get a lot richer with the monoclonal antibody than they are when you're giving them nafcillin. So I think that those are concepts I think that really have to start thinking about in what's driving these things in the progress of medicine. Doing the right thing that's simple, or are we going to go through some elaborate scheme because it's going to result in some revenue generation for somewhere along the line? So going back to these peptides, I mentioned that there's this analogous activity between daptomycin and these antimicrobial peptides. Well, what about resistance to these peptides? Sure enough, that if you look at Staph aureus bloodstream isolates and put them through these platelet microbial protein killing assays at 2 micrograms per ml for 2 hours, you can look at, you can group, you take a dichotomous break in the isolates that had greater than 15% survival or less than 15% survival. These are the ones that were killed, very well. These were not killed so well. And you look at the time of bacteremia clearance, the patients who had more PMP-resistant staph had longer durations of bacteremia. And this makes sense, right? If you have an immune mechanism in your blood that's going to clear the bacteria out, if the bacteria is becoming resistant to, it's going to persist in the bloodstream. In fact, this is a very old paper. This goes back, 40 years, 30 years, 1994, endocarditis versus non-endocarditis, coag-negative staph and Staph aureus. You can see the percent survival in these very similar assays. In endocarditis is above 50%. The non-endocarditis strains are below 50%. So you can predict endocarditis based on susceptibility to these antimicrobial peptides. Endocarditis isolates, by virtue of their virulence of being able to establish an infection, are more intrinsically resistant to these antimicrobial peptides. But what does that mean for daptomycin? Well, it turns out daptomycin-resistant Staph aureus, MRSA, are also more resistant to PMP and HNP. So now we're building the triangle of resistance, right? So now you have endocarditis, PMP resistance, dapto, and PMP resistance. So does that mean that endocarditis isolates are intrinsically more resistant to daptomycin? Well, in fact, actually, it's true. Not overtly resistant, but there's an MIC creep that's already occurring in Staph aureus by virtue of establishing endocarditis before daptomycin has actually even been introduced into the patient. And this is actually a bunch of bloodstream isolates that we simply did e-tests on. We took, and by the way, these strains were all obtained from patients before daptomycin was even clinically introduced. This is back in the 1990s. So if you look at isolates from non-endocarditis patients versus those from endocarditis patients, first you'll notice that there's a lot fewer endocarditis cases because they're just harder to find. But you notice this tail of MIC creep. These are all fully susceptible, all under an MIC of 1. But you start seeing an MIC creep among Staph aureus isolates from patients who never even saw daptomycin, just by simply the fact that they had endocarditis. So I show this article here that many of you probably saw from 2006, daptomycin or vancomycin for the treatment of endocarditis. I think it was actually vanco for MRSA, beta-lactam for MSSA with a few days of gentamicin in there. 6 of those cases developed daptomycin resistance on daptomycin therapy. Should that surprise us if daptomycin is our drug? Well, no, you're giving a drug by which there's a resistance developing in vivo simply by the virulence that's allowing that bug to get there. So I always caution, I never use daptomycin alone in an endocarditis case, especially early on, because if you do, especially after you're giving it after a vanco salvage, and I didn't even get into the whole vanco selecting dapto resistance, you're basically adding fuel to the potential fire. Now, it doesn't happen all the time. Remember, this MIC creep is only in a few isolates, but 6 out of the, I think, 94 cases wound up getting daptomycin resistance on therapy. And it speaks to the nature of the disease you're treating, which you have to be mindful about. It's not just an S or an R, single therapy. You have to be mindful of these other things. I think the home run experiment here was done by the Arnie Bayer Labs back actually over 10 years ago now. This experiment basically showed that you can take an MRSA, put it in the bone of a rabbit, and let it just sit there, and it becomes dapto resistant. Just by simply exposing it in a closed space to the antimicrobial peptides of an in vivo environment, you can get population curves shifting to the right, which means there's a higher MIC. So antimicrobial stewardship is not just what we give patients, right? Antimicrobial stewardship also involves reducing and minimizing the time a bacteria spends exposed to our innate immune system. Because the longer we let an infection fester and without source control and with a high inoculum, it's a failure of stewardship. You're driving resistance in the body by virtue of the peptides and they're already there in the body to fight the infection. So this is the triangle of cross resistance: dapto, vanco, cationic peptides. Unfortunately, to say, standard of care says endocarditis is treated by dapto and vancomycin monotherapy in today's world. I think hopefully I've laid a foundation for you that this is the bad idea, that we really should be pursuing documented endocarditis cases, or potentially cases where endocarditis is very, very likely with combination therapy. There's been studies. This is the Camera 1 trial published in CID back in 2016, where interestingly, this was a study that was done in Australia. Initially, the rationale of this study was to say that if a patient had Staph aureus in their blood, and back then, 10 years ago, rapid diagnostics were not really, part of standard of care. So the thought was, if we started flucloxacillin early on, the patients with MSSA would get an advantage as opposed to waiting for susceptibility to come back and switching the vancomycin to flucloxacillin. They wanted to get, the beta-lactam on board early in case the patient had an MSSA and get a head start on the MSSA infection. When we presented our data that I just went through at their meeting back in I think it was 2013 or 2012, they actually changed gears and said, well, because it didn't make a difference for their MSSA patients. But sure enough, they found in their MRSA patients that the patients with the durations of bacteremia who got combination therapy was only 3 out of 46, whereas 13 out of 49 who got monotherapy with vancomycin clear. So they wind up doing Camera 2, which I'll talk about in a little bit. But generally, people, you talk about combination therapy with Staph aureus and MRSA bacteremia, and everybody kind of puts it aside. There's no data, and there's the editorial, and JAMA said it's not ready for prime time and all this stuff. It's because it just hasn't done well. The vanco-rifampin study from the early 90s, vanco-gent, we don't do gent anymore, from that paper that I talked about in New England Journal. The Camera 1 and now subsequently Camera 2, vancomycin plus anti-staphylococcal penicillin, the flucloxacillin, as I'll talk about, they stopped that trial early. And then the Ixabacase study that was just done a couple of years ago also failed. So it really, under the, drug X running a 5K did not do well. I mean, it did not do well in that model. I want to point out a few details though on Camera 2, because many view that as the so-called gold standard for combination therapy against MRSA. I think it's a gold standard in a clinical trial design viewpoint. However, it is not really a gold standard trial given what we know about beta-lactams and how combination therapy should be used. What these guys do is what these guys did, vancomycin or daptomycin. Now, the title of the paper is vancomycin or daptomycin, but only 3 patients in the combination group and nobody in the monotherapy group got daptomycin. This is basically a vancomycin with or without flucloxacillin trial. There was really no daptomycin really was. So the title is deceiving. Dapto is really a handful of patients, if that. So they rolled multiple patients in multiple sites around the world, stopped early due to 30% developing AKI in the combination vanco plus flucloxacillin group versus only 9% in the standard treatment arm. And the mortality, while not statistically significant, was up about 5%. But they did clear their bacteremia quicker, as they had found in Camera 1. The real take home point home of this article, many of you probably already, would call this an, oh, wow, study. From vancomycin, vanco plus flucloxacillin is probably not a good idea because it's going to cause AKI. What they did show, though, is that vanco plus cefazolin, which the folks at Wayne State are using quite often, is not associated with AKI. However, vanco plus flucloxacillin and cloxacillin are associated with AKI, superimposed on the already, somewhat added risk with vancomycin alone. And they did a post hoc analysis of this trial, and they found the independent predictor of nephrotoxicity was not just flucloxacillin exposure, but also the AUC. So in a decade where we're pushing AUCs and troughs 15 to 20 to get higher levels on top of the penicillins, I think it took, kind of a perfect storm of a situation to enhance the nephrotoxicity risk. If you actually look at the literature and look at the beta lactams that have been combined with vanco, and some show nephrotoxicity risks, some do not. You can actually plot that prediction risk based on the hydrophobicity of the beta lactam. So flucloxacillin and cloxacillin and piperacillin are all hydrophobic drugs, and they all raise their AKI. It's kind of interesting, actually, if you look at the partition coefficient, water to octanol, or octanol to water partition. It actually serves, and I mean, there's only 3 dots, but it turned out to be a fairly linear based on the published data of relative risk of AKI on top of vanco alone. Drugs like meropenem, sulbactam, cefazolin, ampicillin, ceftaroline, ceftobiprole, these are all hydrophilic drugs. So you're not, and for drugs that, for the data being available, which are these dots, there is no added risk from AKI. So you can really look at this for any future beta lactam that comes out there. You can actually look at the hydrophobicity of the beta lactam and predict the nephrotoxicity. So when we sort of, to follow up the vanco plus nafcillin, or the dapto plus nafcillin story that we had a few slides ago, that those cases turned out to be pre-ceftaroline days. Now in 2011-12, ceftaroline emerged. So a lot of experts are saying, well, why are you using nafcillin? You should just use ceftaroline because ceftaroline has intrinsic MRSA activity. So this study was, the story behind this study. The first study is that first, when I started using daptomycin and ceftaroline combination therapy, my antimicrobial stewardship pharmacist came knocking on the door. This is pre-dapto being generic. And it says, well, why are you doing this? What's the foundation? I said, well, okay. I said, I showed her the literature we'd done in the lab. I said, why don't you look at the patients that and see how they've done? And sure enough, they had a residents do a DUE, a drug utilization evaluation. And they found that there was no mortality in the patients who got combination therapy versus a 25% mortality for similar patients that were matched who got standard of care. So that kind of put the stewardship people away because, if you show no death, then they leave you alone. But that really kind of that was actually surprising to us, actually. So that inspired us to try to get some momentum to get a prospective study going. So Forest Pharmaceuticals, who had ceftaroline at the time, was going to fund this study. But they decided, of course, going back to the money and drugs thing, they decided they were going to put their antimicrobials on portfolio on the market and not invest in a clinical trial. So the money was withdrawn. There was going to be a study with Mark Zervos, myself, and a couple of other folks, and I think Donald Bean was going to be part of that study. But they pulled the funding, and we couldn't do it. So we decided to kind of put together going back to basics, right? At the end of the day, we do a lot of analysis with, power calculations and ands and sample size and paying homage to statistics. At the end of the day, what do you want to know? You give this versus that, what's going to happen to the patients? So we decided we're going to do a prospective open label trial at 3 sites. And randomize people to get vanco or dapto monotherapy or dapto ceftaroline combination therapy within 48 hours of positive blood cultures for MRSA. And we're going to enroll 54 patients. I could tell you, patient 40. Again, it was an open label trial, so we knew the numbers already, and we knew we already had no deaths in the combo arm, and I think it was 5 or 6 deaths in the other arm. And my pharmacist, who was the first author, Geriac, on this study, George, you really want to enroll another patient? I said, every other study in the In the United States, any other country, hospital, they'd be getting vancomycin. So what's, we'll enroll the patient wound up dying because vancomycin was our sixth or seventh death in that study. So at that point, I realized that, we couldn't ethically continue the study. If your person enrolling the study knows that, is seeing a difference, and it actually, doing calculations at that point, after 40 patients, there was statistical significance. We decided to stop the study. And, enough of this, preset, a priori, all this statistical stuff. End of the day, we gave 17 patients combination, all 17 survived. We gave 23 patients standard of care because that's how the way the randomization had pooled at that early stage, and we got 25% mortality. End of story. I mean, we on ethical grounds had to stop the study. Here are the Kaplan-Meier curves. They're Charlson scores, pit bacteremia scores, and bacteremia durations are listed all here. No difference really in that category. So that really kind of set the stage, and we published the data. Of course, the statistical worshipers, had a lot of limitations and all that. At the end of the day, clinicians rule, right? The statistician, but unfortunately in clinical trials, right, the statistics has become the tail wagging the dog to some degree, right? It's something that is a necessary part of how we do things. But what is medicine, right? It's drug A versus drug B. How do they do? I mean, that's if I have to enroll 1,000 patients to show a difference, what does that mean? I mean, what does that mean clinically, right? So what we decided to do at our hospital, then we decided to take a look. This is of last year. We had our pharmacy student. Actually, it was a pharmacy resident who did this particular project. We wanted to look at all the patients who got early daptomycin plus ceftaroline, because daptomycin and ceftaroline is typically used as a salvage regimen, and the salvage threshold is changing from like 7 days to 5 days to 3 days. It's moving shorter and shorter. But we wanted to look at people who got it within 3 days of knowing they have MRSA. And so between our trial, between our various analyses, we had 51 patients who got the combination treatment, and we had one death out of 51, a 2% mortality at 30 days, and actually nobody died in hospital. So everybody left the hospital alive. We matched patients with the monotherapy arm. The monotherapy group, same hospital, same level of illness based on age, renal status, and source of bacteremia. They had a 14% mortality with standard of care, which is on par with what the CAMERA 2 trial. So the CAMERA 2 trial that I mentioned earlier had 15% in the combination and 11% in the monotherapy. Our monotherapy arm was right sort of smack in the middle of that CAMERA 2 analysis. But so we, pretty good survival, significant survival benefit with that combination used early. So we adopted a protocol at our hospital system, system-wide in our healthcare system to use this combination as induction if both admission blood cultures are positive and they have at least one of the following: person who injects drugs, risk of endocarditis being high; a hemodialysis patient, who I'll explain to you if some of you may heard me talk during morning, what I call qualitative thrombocytopenic patients. The patients who have thrombocytopenia are those whose platelets are dropping quickly. Those who have patients have bacteremia that has relapsed in 3 months. A hematogenous vertebral osteomyelitis, because about 1/3 of those patients are going to have endocarditis to begin with. And then an ICU admission not due to an obvious pneumonia source. Someone in septic shock who's going GPCs in clusters, we use that combination. And that duration is only, during the hospital stay or until the infection is deemed stable, ready for discharge. And then they go out, Vanco, Remeslid, whatever it is, it doesn't matter what day, but so it's, or Dalbavancin once a week. We've had several of those that are recently, and then, or whatever de-escalation therapy of choice. So that's how we've adopted this, potent therapy focused on these patients. I'll talk about the platelets because the platelet, actually, we tend to ignore in ID. The platelet is actually the most important immune cell in the bloodstream, partly because of this antimicrobial peptide I was talking about. If you have a Staph aureus bacteremia, you would rather be neutropenic than thrombocytopenic. The mortality follows the platelets, not the neutrophil count. Neutrophils are important in tissue-based infections, but once you're in the bloodstream, the platelet really predominates as a form of immunity. And if you keep an eye on your persistent bacteremia patients, they may or may not have a low platelet count, but if they do have a low platelet count, they probably won't clear their blood until the platelet count starts going up. The dialysis patient, right? We talk about the uremic platelets in terms of clotting. That uremic platelet phenomenon also applies to their immune system. It's not a coincidence that those patients, are the ones that have the most complicated, persistent infections because their platelets don't work. They have qualitative thrombocytopenia, not quantitative. Um, I want to talk about some deep salvage cases that I were involved with because sometimes you got to go escalate. So this is a 64 end-stage renal disease on hemodialysis via tunnel catheter, MRSA bacteremia on Vanco for 3 days, switched to dapto and ceftaroline. One month prior, the patient had low-grade bacteremia. They changed the dialysis catheter and sent the patient on a Piolinesa for 14 days. Moral of the story here is call an ID consultant. An ID consultant seeing that patient would have never had this position, especially in a dialysis patient. Anyway, needless to say, we've now sort of gotten the pharmacy involved to call the ID on call whenever there's for Staph aureus. So they had a person's bacteremia despite 7 days on dapto and ceftaroline. It was a vegetation at the tricuspid valve. Platelet count low. Okay, so you have not only a qualitative thrombocytopenic patient, but a quantitative thrombocytopenic patient. So what to do next? So I'll tell you what we decided to do. Albumin of 2.7. We added ertapenem, 500 24 hours, and bacteremia cleared in 24 hours on the third agent. So after 1 week of triple therapy, they discharged 4 weeks on dapto and ceftaroline, and then we gave them doxy-PO for 2 months, and they were relapse-free as of 2 months. I don't have any follow-up after 2 months, but so that was one thing we did. And I'll talk about, so this is the second case. This is sent to me by actually in July. I got a call from Lafayette, Louisiana, from this colleague who had a patient with a recurrent MRSA bacteremia 2024, February, then April of 2024, then end of June, shortness of breath and fever, MRSA bacteremia, MIC of 2, dapto susceptible, ceftaroline susceptible. They were given vancomycin and ceftaroline, no clear source identified. A T showed immobile elements on the mitral valve leaflet, probably a small vegetation. Blood cultures positive for several days, 26, 28 to 7-3, 24. So Vanco was switched to dapto, and then they were dapto and ceftaroline. So blood cultures continued. We added meropenem, 2 grams Q8. When he called me, what to do next with positive blood cultures. Albumin of 2.5. So we added mero, not ertapenem, because I'll talk about it later, that ertapenem, hypoalbuminemia, is associated with treatment failure with ertapenem. So blood cultures remain negative. Patients got triple therapy for a week and then combo therapy for 6 weeks for the endocarditis. So this slide got a little warped, but carbapenems, as I've talked to you, probably some of you this morning, have more perhaps than just antimicrobial effects. They may have immunologic effects, enhancing neutrophil and monocyte function. You can actually look at patients with bacteremia, those who have persistent bacteremia for greater than 4 days. All of them have normal IL-1 beta levels. Not all patients with normal IL beta levels have persistent bacteremia, but all patients with persistent bacteremia have low IL-1 beta. So the failure to mount an IL-1 beta response seems to be predictive of a persistent bacteremia. You can actually look at Vanco-treated patients versus Vanco plus beta-lactam treated patients. And you can see that the IL-1 beta response is much more robust in a beta-lactam treated patient than a Vanco therapy patient. So maybe Vanco is in it for a reason, chicken or the egg. We don't know what the reason is, but if Vanco monotherapy fails to elicit an IL-1 beta response in patients with bacteremia. So this is a study done by Warren Rose's lab. You can actually induce IL-1 beta with cefazolin and ertapenem combination therapy, even in the absence, in peripheral blood mononuclear cells, even in the absence of Staph aureus. So there's some, immunologic talk between carbapenems and white cells. If you think about this, right? I mean, the immune system, the antibiotics from the primordial soup are probably the origins of innate immunity, right? When small single cellular organisms or yeasts are producing antibiotics in the soil, that's probably the beginnings of innate immune system in higher animals. So it's no surprise that there's a communication between antibiotics and innate immunity. So here's one example of where that happened. So if you look at adding ertapenem to various agents in a murine bacteremia model, this is a control, ertapenem alone, meropenem alone, ceftaroline alone. If you combine ceftaroline and ertapenem or ceftaroline and meropenem, you get a marked reduction in CFUs in the kidneys. You can do the same thing with Vanco. You can add ertapenem and meropenem to vancomycin. You can actually enhance the killing there as well. So, carbapenems, very important agents in our gram-negative world, but they also seem to have an effect beyond the MIC and beyond what we would normally expect. Even among ceftriaxone-resistant MRSA, ceftriaxone MIC here is resistant. You can combine ceftriaxone and meropenem or ertapenem, and you can get killing. So I want to see how much time I have here. Okay, I got a little bit of time. So MSSA endocarditis. This is an index case where we had a line of reasoning of a 32-year-old IVU. I guess now you say PWID, admitted to the hospital with shortness of breath, vancomycin and ceftriaxone because to the ICU for the first 24 hours. Gram-positive cocci, ID was called. Ceftriaxone and Dapto was started. Verigene later on that day showed it was MSSA, so we switched them to nafcillin. I think they got 1 dose of ceftriaxone and Adapto, and then switched to nafcillin. Multifocal pneumonia, septic pulmonary emboli, a very, very, very large vegetation on your tricuspid valve, 3.2 centimeters, on nafcillin for 5 days. So at first thought, you're saying, okay, source control, right? So you do an angiovac or get a surgeon to clear this out. You you want to see a surgeon run fast, call them to see one of these patients. They run, they run out of, that's pretty much a 40-yard time on a surgeon. They run out of the room as fast as possible because they don't want to operate on these folks that are actively injecting drugs. If you intervene or replace a valve, they're going to get reinfected. So we added ertapenem. We did ertapenem and cefazolin combination therapy, and I'll tell you why in a second. In 24 hours, you had negative blood culture, which is pretty phenomenal, right? 3.2 centimeter vegetation, and you clear the blood in 24 hours. That was not something that I was, expecting. So once you made the patient better, then interventionalists got more excited. Then, they're feeling better. They cleared their blood. They're on the floor now. They're not in the ICU, hypotensive. I did an angiovac procedure, which many of you may have heard of. It's a device that was from Latham, New York, that was developed to fish out clots from the pulmonary emboli. Now they're employing these and removing vegetations on the right side of the heart. Of course, after 4 weeks, he signed out AMA. Kind of, these guys know he had nowhere to go. I guess there was a disposition issue, so he wound up leaving the hospital. So we added it because of sort of analogous story to what you would expect with ampicillin and ceftriaxone. Ampicillin being the most active agent against enterococci, but there's penicillin binding proteins that ampicillin does not bind to an enterococci, so you need ceftriaxone. Even ceftriaxone is not particularly active. It doesn't enhance activity of ampicillin. So using that line of reasoning, we added it to this patient. We took in an endocarditis model, and actually the late Barbara Murray, who many of you may have known, she passed away earlier this year, ran this model for us, and she was surprised at how well ertapenem did by itself in this model. And again, I think it speaks to that immunologic effect that the carbapenems are doing. But needless to say that all but one of the rats' vegetations was sterilized. So we used it in salvage. I know, talked to some of you today. I think you guys may have used it here. Happy to hear the cases you may have used it in. There have been cases now published where ertapenem was added to oxacillin, not necessarily cefazolin. The way we do it is, so here's some dosing strategies, ertapenem with either nafcillin, oxacillin, or cefazolin. So with that, I'll end so I could leave some time for questions. I think endovascular infections, highly suspected or definitely confirmed endovascular infections, require our most aggressive antimicrobial regimens, whether it's MRSA, daptomycin, and ceftaroline, cefazolin, or an staphylococcal beta-lactam with a carbapenem, with MSSA. I didn't get into it for the purposes of this talk, but daptomycin and ampicillin is also a potential role in VRE. A low threshold for source control, because remember, if that infection festers and it's exposed to the immune system peptides of the body, you're going to potentially drive resistance to drugs you haven't even used yet. Patients with high risk, patients with positive blood cultures and endocarditis should not die on the hill of antimicrobial stewardship, right? Antimicrobial stewardship is meant for durations of therapy, meant for those who are not infected to, avoid antibiotics in patients who are not infected. It's really not meant for people with a bona fide, vegetation, positive blood culture for many days. I think that mindset has to leave, because your job then is to save the life of the patient, because the mortality and morbidity is not small. And I think we need to really be careful. I'll give this presentation in some places, and they'll tell me like the pharmacist won't let us. I mean, what do you mean the pharmacist won't let you? I mean, it's like, I mean, you're the doctor, right? I mean, you've got to do what you got to do. But in some places, I guess they have iron control of these antibiotics. And I think it's inappropriate for someone who has a bona fide, grandpa, a Staph aureus endovascular infection. And I'll end it with this, if an infection is worthy of an ID consultant, vancomycin is probably number one. I think other than as a step down agent, certainly in the acute throes of an illness. So I will end there and leave time for these are extra slides. So thank you for attention and for inviting me, and hopefully it was informative, and I hope even more that you have some questions. So thanks again.
My friend Chuck Stratton once said that the difference between an MIC and disc testing was that an MIC will give you a decimal point, but it's basically putting you in the ballpark. I mean, I think these are interesting data. And I'm not sure I can, since I don't take care of patients anymore, I can't comment further.
A lot of folks. Oh, talking about the question. I think a lot of the questions that are being asked, right? I mean, they're not being asked by people that are spending time at the bedside. I didn't tell a bit about myself. 75% of my time is spent at the bedside. I mean, I see patients in consultation. And so I need this stuff. Like I need, this is a survival tactic. It's not an academic kind of curiosity, right? I mean, a lot of these were driven. I mean, I saw the cases that 21 days of bacteremia, the days in the hospital on positive blood cultures. These are things that are, the folks who called me, these are folks that are like, I'm there, I got to do something. I mean, nothing is working and I have to do something. So I think questions that are arisen from those desperate cases and outlier cases. I mean, I think we're taught in medicine to focus on means and medians, but ID is our patients are dying from outliers. I mean, even COVID, right? 90% of people, 80% of people get COVID, don't even go to the hospital. 10%, 20% go to the hospital, and of those, maybe 20% die. So the outlier is what kills us, right? But we're focused on means and medians. That's the dilemma we're in, is we're focusing on means and medians because statistically that's the easiest thing to focus on. We don't focus on that tail population, the camera 2 trial the camera trial that I showed, that percentage of patients whose bacteremia cleared earlier went away with the combo arm. I think we have to pay more attention to these outlier cases because, nobody questions what to do when you have a soft tissue infection with MRSA, 1 out of 4 positive blood cultures. Yeah, we all know do there. It's what do you do for a dialysis patient with a platelet count of 50? This is their 3rd bacteremia in a year, and they don't clear their blood after a week. There's no, Vanco is not the answer for that patient. So it's just not. Yeah. Question. Oh.
Yeah, that was a great talk. Thanks. So with some of these combination regimens that I've used, when I've started incorporating them a few years ago, based on some of the studies you showed, a lot of times we would do the combination therapy and the patient would clear. And then after a week or 2, we would drop off one and just do monotherapy, because I think that was sort of more of a comfort based on historical data. But do you keep the combination therapy for the duration of your treatment? And then the second part is, do you do any oral step down therapy with more data coming out showing, oral use of antibiotics in situations we used to use IV? And if so, do you have certain oral anti-staphylococcal oral antibiotics you think work, are more effective than others?
Yeah, I think that's a great question. I think that's, I'll probably bring out that point more in tonight's lecture. I think the point of what you start on day 1, 2, or 3 does not have to be day 30, 32 treatment. There's an induction consolidation mentality. I mean, when the patient is in the throes of their illness, the inoculum is highest in the hospital, like we said, we do exactly what you described. You know, we in the 7 days while they're waiting for blood cultures to clear to get their PICC line put in, getting the imaging, getting the cardiologist to do a TE. Yeah, they're getting the combination. Once they come time to leave, they'll go on vancomycin, they'll go on daptomycin. We've had increasing number of patients go on dalbavancin weekly for a couple of doses when they leave. So the step down question is a great one, because I think the answer is, I gave a presentation on this last year at ID Week. The question is, if you're aggressive up front with these agents, the patient groups that you can step down to oral increases, right? If you're sitting covering baby steps on vanco for day 1, day 2, day 5, day 7, you've covered no ground. So the percentage of patients that you can go to oral step down comfortably is less. If you cover a lot of ground with, whether it's surgical debridement or pharmacological debulking, which is what you do with combination therapy, by the end, I mean, if I have a patient whose CRP has gone from, 300 to like 30 in a week, yeah, I'll send him home on a couple of weeks of linezolid or doxycycline. Minocycline is one of my favorite agents I like to use. I think the other thing you have to keep in mind, again, I talked about age. The age of the patient. Young patients, I've sent several patients home with endocarditis after they've gotten their 7 to 10 days in the hospital on oral tedezolid or linezolid. I don't usually like doing linezolid for more than 10 days because of the low platelet issue, especially with what I talked about platelets. But tedezolid is much less likely to cause thrombocytopenia. Minocycline is another one that I use. So I think oral step down, this is the gateway to more oral step down patients, because you're actually getting all the work done. You're covering more ground and getting rid of that infection early on. And then you can do, the battle's over. I tell people, each passing day, it's like you're treating you more than the patient. You've done the bulk of your therapy in that acute phase. So yeah, thanks for asking those questions. I think I'll talk more about it tonight, but I think that those are important points to bring up. Yeah, there might have been questions that popped up here. Oh, here. Let's see. Where's the chat? How was that, man? We clearly have the data regarding benefits combination. Do we think this applies to coag negative staff? Oh, very good idea. So good question. Does this apply to coag negative staff? The answer is yeah, it does. It's funny, we had kind of done a study years ago. We had a visiting student do a coag negative staff paper or project, and she went off back to Belgium and she never wrote the paper up. And then I was asked to be a discussant on one of these in a coag negative staff endocarditis case. And we resurrected data. And sure enough, we found the same applies, the synergy with nafcillin, ceftaroline. Coag negative staph is actually an important thing to bring up, because staph epidermidis or coag negative staph left-sided endocarditis has the same mortality as MRSA endocarditis on the left side. The mortality actually doesn't follow the bug. It follows a methicillin susceptibility. Most coag negative staph are methicillin resistant. So the fact that you're not using nafcillin, oxacillin for these coag negative staph, and you're having to use a drug like vancomycin, again, I think speaks to that as well. So the answer is, if we have a serious coag negative staph infection, we treat it like an MRSA infection, because we know that in left-sided disease, it has the same prognostic implications as MRSA, because again, it follows the beta-lactam resistance phenotype. So thank you for asking that.
Great. Well, George, thank you so much. That was a great talk.
Thank you.
And remember, being encore tonight with 3 of our other illustrious staff, faculty members will be speaking at the SNANI Symposium tonight. So be sure to get there early and stay late. So thank you so much.
In progress.
I'll make sure you stay late. I'll go over.
Okay, I was just about to turn this off and head down there. No, right, because I went and talked with Deborah as soon as we left. I wanted to make sure you guys were okay. No problem. I'm on my way down as soon as I cut this thing. Yeah, it's presenter view should be up there, but I'll be down.